everyone. Good afternoon. Welcome to our HMA webinar on integrated support to reduce ICU complications through early mobilization, organized in partnership with Baxter. I'm Cindy, Content Manager at Hospital Management Asia, and I'll be your MC this afternoon. Today, we have invited a panel of healthcare leaders to discuss best practices in early mobilization of ICU patients. Research has shown that getting ICU patients moving as early as possible helps improve recovery outcomes, shortens length of stay, and reduces the risk of complications such as delirium and pressure injuries. So what are the key ingredients and considerations behind an early mobility program? Over the next 1.5 hours, our speakers will share their expertise and observations from their work in early mobility so far. We will have a 20-minute Q&A session at the end, so feel free to type in your questions in the Q&A box at the bottom of your screen, and we'll get to them if time permits. All right, without any further ado, I'm pleased to introduce our first speaker, Dr. Yuwadi Kesumpun, President of Thai Enterostomal Therapy Nurse Association, President of Thai Oncology Nurse Society, and Executive Board Member of Thailand Nursing and Midwifery Council. Dr. Yuwadi, please.
Good afternoon, everyone. Today, I'm going to explore the nursing perspective on early mobilization, an essential but often underappreciated part of recovery. I shall look at what nurses are already doing, the challenges we face, and how we can move forward with better teamwork and policy support. As I imagine 50 years ago, when I was a new nurse, it was just the doctors and nurses, and the nurses were the ones responsible for helping patients stand, walk, and regain their strength. What we now recognize as early rehabilitation was a fundamental part of our daily nursing care back then. Today, the practice is now as early mobilization and is supported by dedicated team and research. Yet, one thing remains constant: the nurse is still the first person at the bedside, the one who observes, make critical decisions, and take action. This slide shows that from early ambulation to early mobilization is a legacy root in nursing. Early ambulation began in the late 19th century, led by nurses and midwives to prevent complications after surgery or childbirth. In 1902, Dr. Cronin promoted postpartum walking within 24 hours, but it was nurses who made it happen at the bedside, patient by the patient. For early mobilization, from the 20th century, early mobilization became formalized in ICUs. In the 2009, Dr. Needham and Dr. Pronovost showed that early activity reduced ICU acquired weakness. Protocol like ABCDEF bundle, followed by bedside nurses, still play the leading role in the making it real. This slide shows the definition of early mobilization. Early mobilization refers to the initiation of physical activity or movement ranging from passive range of motion, exercise, to out-of-bed ambulation within a defined early period of a patient's hospital stay, particularly in critically ill or high-risk patients. Goal of early mobilization to prevent functional decline is that to promote recovery and reduce complications associated with prolonged mobilization. The next slide, I will show you the importance of early mobilization across care settings. Early mobilization is important across all care settings, from ICU to general ward. Surgery to rehab is help prevent serious complications like pressure injuries, blood clots, delirium, and muscle weakness. It also support faster recovery, earlier discharge, and better functional outcome. Most importantly, it restores both physical function and dignity of our patients. And throughout all this, nurses play a central role in making safe, effectiveness mobility happen. The next slide is the nursing role in early mobilization. Nursing are the heart of early mobilization. We don't just follow orders, we observe, we design, act, and protect. Here's now we lead this process every day. First, before starting any movement, we assess vitals, oxygen levels, alertness, and pain. This ensures the patient is safe to move. For example, a nurse might postpone walking a patient whose blood pressure dropped after medical and recheck in 30 minutes. Second, whether the passive limb exercise or helping a patient stand, nursing are the one who initiate and support safe movement. The example that we see in a step-down unit, a nurse help patient dangling their legs over the bed and post op day one. The third that we use timing, schedule, compression devices, and mobilization techniques to prevent complications from immobility, like pressure injuries or blood clots. Example of this situation, a nurse repositions a stroke patient every 2 hours and promotes range of motion to patient contracture. The first one that we see the nurse monitor the sign of intolerance like dizziness, desaturation, or fatigue, and adjust care immediately. For example, in this case, like during ambulation, a nurse noticed that the patient become pale and short of breath and safely return them to bed. The fifth one is that we communicate with the doctor, therapist to align care goals and mobilization plan. Example of this, we see a nurse recommends holding sedation during round to support a patient readiness to sit at the edge of the bed. And later we teach the patient and caregiver about the importance of movement and how we safe participate. For example, a nurse told a family how to help their loved one do ankle pumps and shift position at home. And lastly, we record and what was done, how the patient tolerated, and what the next step should be. For example, the patient stood with assistant with 3 minutes, no dizziness, plan to walk 3 steps tomorrow. With the documentation, the care team will look at what is the progress of the patient in each day. The next slide, I will be talking about the teamwork and collaboration in early mobilization. Early mobilization doesn't happen in isolation. It's a team effort. Nurses assess and initiate. Therapists guide progression. Doctor adjust treatment, and patients play an active role too. When there's strong collaboration, we move safely and efficiently. but what's role are unclear or communication breakdowns, delay, and risk increase. That's why we need structured teamwork, share plan during rounds, nurse-initiated discussion, and constant feedback. Because we mobilize together, our patient move forward faster with fewer complications and better outcome. For example, to show this, if a nurse notices a patient is alert and breathing well, but still sedated unnecessarily, they can speak up during rounds. When the doctor adjusts the sedation, a physiotherapist is informed the same patient might set up be by the afternoon instead of losing another day in bed. In this slide, we will show the empowering patient and family. During mobilization, it is not only the nursing job, it's a shared journey when we educate the patient and families on why movement matters, that became active participant in recovery. Even small action like sitting up or doing ankle pumps can make a big difference. It reduces dependence and empower them to take control of their health, not just in the hospital, but at home too. This slide, we're talking about safety of mobilized with clinical judgment. As a nurse, we must remember that not all mobilized is safe. Mobilizing patient at the wrong time or the wrong way can lead to injury or deterioration. Nursing must assess and patient condition carefully, vitals, line, cognitive status, and work with physical therapists and doctor to plan safely. I give you some example. In case 1, a 72 years old post-surgical patient was assisted to sit on the edge of the bed within 12 hours after abdominal surgery. However, the patient had under-recognized orthostatic hypotension and become dizzy, result in a fall from the bed. This incident lead to a re-evaluation of the unit mobility criteria. In a case example 2, a 65-year-old man, patient with a sepsis and acute kidney injury, had fluctuated blood pressure, high respiratory rate, about 28, and muscle weakness. A nurse attempted to ambulate him without full assessment of all physician input. The patient collapsed from hypertension, requesting emergency intervention. And risk of inappropriate mobilization that can make the patient very serious condition. While every mobilization has many benefits, doing it at the wrong time or the wrong purpose, proper assessment can cause harm. Patient may fall, desaturate, or experience a sudden drop of blood pressure. Lines and drains might dislodge, or patient may simply not be ready. That's why clinical judgments, teamwork, and readiness checklists are essential. Safe mobilization is not just about moving, it's about moving at the right time, with the right plan, and with the right support. For early ambulation readiness checklist, I start with before we mobilize any patient, safety must come first. This checklist ensures we assess readiness in the structure's evidence-based way. First, we check vital signs, heart rate between 60 to 90, systolic blood pressure at or above 90, respiratory rate under 24, and oxygen saturated and or above 90%. This indicator tells us the patient is physiological stable. Next, assess neurological status. The patient should be alert, oriented, and able to follow simple commands. This is essential for cooperation and safety. For respiratory function, make sure that no visible distress or that oxygen requirements are not increasing. From a hemodynamic perspective, the patient should have active breathing or be a stable or no vasopressor support. Always check the line, choose and drain and secure and manage for movement. This road line can then be dangerous and lead to serious setback. Pain should be well controlled, ideally with the pain score or 4 or less, or at least tolerable enough to allow activity. Strength should be assessed. Can the patient lift limbs or hold their head? Even minimal strength can guide what level of mobilize is appropriate. Finally, confirm there are not contraindications such as unable fractures, deep sedation, or ongoing breathing. If all boxes are checked, the patient is ready to begin self and graduate mobilization. Remember, this is not just a checklist. It is a clinical thinking tool that to empower nurses to lead mobility safer. This slide is show that who benefits from this early mobilization when we talking about the disease specific. With early mobility must be adapted to each patient condition. Let's look at how nursing play a central role across common clinical context. The patient with stroke in our role focus on supporting safe sitting, maintaining balance, and preventing falls. These patients are at high risk for contractures and functional decline. So early guides movement help promote neuroplasticity and support their recovery pathway. Even setting up with support can stimulate orientation and strength. For the benefit of the heart failure patient, we must be cautious. The key is graduate pacing, careful vital sign monitoring, and avoid exertion. Mobilizing too aggressive can cause decompensation. With close assessments, safe movement can improve cardiac function and physical tolerance. With the post-surgery, surgical patient benefit from mobility within 24 hours. Provide plan is control. Movement help prevent deep vein thrombosis, post-op ileus, and lung complication like atelectasis. Nurses often lead the first out of base activity, ensuring line and wound are protected. For ICU patient, which I will explain in more detail later. And in this slide, for the ICU patient, the mobilization or mobility starts small. Think of it as a stepwise process. Passive range of motion, then sitting, then standing. These patients are fragile, but movement is essential to prevent ICU acquired weakness and delirium. Nurses are this bedside at the one who assess readiness and initial care step. For disease specific, the last case that I give you for example is the orthopedic cases. With the orthopedic patients, we focus on protecting the surgical sites and guiding weight bearing based on physician and physiotherapist input. Early step movements prevent joint stiffness, maintain alignment, and promote bone healing. So across every condition, nurses are the ones who adjust, lead, and individual early mobility. It's not just about getting patients moving, it's about moving them safely, purposefully, then in the right way for them condition. For this slide, a little bit of storytelling that I will show you how one nurse changed our culture. Let me tell you a true story. In a general ward, a patient had been aligning in bed for days with no sign of movements plans. One nurse decided to begin daily passive exercise. She encouraged the patient each day, just a little move, a little more movement, a little more trust. On day 5, the patient stood with support for the first time. That moment changed more than just one outcome. It inspired the team, got the attention of senior staff, and led to the creation of a formal mobility policy in this unit. This is the power of nursing leadership, not just a clinical skill, but persistence, vision, and care that drives symptom-wide change. This slide, we're talking about helping nurses to get resources. As you listen to me from the first slide, I keep telling you that the nurse is the person who are at the bedside, and then they work constantly next to the patient in every day, 24 hours, and in 7 days a week. So is it important for us to helping nurse to get resources? For nurses to carry out every mobility effectively, we need more than just motivation. We need the right resources. The mean having time built into our workflow, enough staff to assist, and access to the right tools like electric beds and transfer device. Technology can help too, whether it's documenting mobility easier or tracking easy in progress across shift. Most importantly, we need hospital policies that recognize early mobility as a core nursing responsibility, not an extra task when leadership support it. And a system aligns nurses can confidently and safely got patients' movement. With this slide, from my experience, I know that sometimes nursing do at the bedside, try to do early mobilization to the patient, but the staff or even the caregiver look at the nurses and try to protect or prevent them to do the good job. So at least if the hospital had the policy and make this activity is a norm, so at that time, nurse to get a very good support from the policy. The next slide that I start to make more clearer in the early mobilization in ICU. After discussion early mobilization in general, let's now focus specialty on the ICU setting, where mobility is both most needed and most challenging. In the ICU, our patients are often sedated, ventilated, and connected to multiple life support devices. This level of clinical illness significantly limit their movement and increase the life for complications like ICU acquired weakness, delirium, and pressure injury, even within the first 24 hours of admission. Many ICU nurses hesitate to mobilize patients because the vital concern, hemodynamic instability, fear of unplanned extubation, or simple not enough staff to save assist. But even small action, right, raising the head of the bed, sitting the patient at the edge, or helping them stand with support, make a measurable difference. And most importantly, ICU nurses play a central role in this process. Daily mobility assessment, clear goals, and the use of support equipment like advanced ICU bed can turn early mobilizations from challenge into the routine part of care. From this slide, I will show you why early mobilization matters in the ICU. Let me begin with the why. Within the 48 hours of immobility, patients begin to lose muscle mass, especially fast twitch muscle fiber. This loss leads to the ICU acquired weakness, prolonged mechanical ventilation, pressure injury, deep vein thrombosis, and even delirium. But most importantly, early mobilizations reduce ICU lengths of stay, improve oxygenations, and help patients regain independence faster. It's not just about discharge survivals anymore. It's about quality of life after ICU. For this slide, the patient population who benefit most, even patients with severe condition benefit from movement. For instance, post-operative patient recovery lung function quicker. Mechanical ventilated patient can sit or stand with the support and show better outcome. With the stroke patient, gain neutral recovery faster with a physical engagement, and generic and fail patients often neglect a mobilization plan benefit enormously in preventing the condition. The message is, if they are medically stable, they should be moved. This next slide, the barrier faced by ICU nurses, clinical organization barrier. From this, in spite of the benefits, many ICU teams hesitate. Common barriers include fear of patient deterioration, lack of confidence and handling lines and tube, short staffing, especially during night shifts, absence of standard protocol, communication gap between nurses, physicians, and physiotherapists. We must address these concerns, not ignore them. The fear is understandable, but with protocol, we become manageable. The next slide, we support for the ICU nurse. To overcome this barrier, nurses need tools and allies. Support includes multidisciplinary round, whether mobility is a daily discussion, protocol that outline criteria and steps, education program for ICU staff, and build confidence, leaders support. This makes mobility and priority. And last, proper equipment and well discussed and into more depth shortly. After all help shift the mindset from wet until stable to mobilize to stable. For stepwise ICU early mobilization protocol, we readiness assessment, cardiopulmonary parameter, vasopressor, etc. Set goal today, passive length of stay, tomorrow sit on the edge, and next walk to floor, walk to door. Allied tasks, who assist the ambulations, physiotherapists, or the nurses. Document and communicate. Ensure follow through during shift change. With the approach, we build safely and consistently. So the next slide is very important that I will show you that the support technical technology and equipment will help the nurse in ICU feel better. With technology, we can turn early embolization from risky to routine. Let's look based and mobility text like Huron Progress Bed, designed for ICU early mobility program. They have 3 modes: progressive mobility system, tilt, rotate, the patient orthostatic response, full chair position, bed to chair in bed, and stand assist with nurse control setting. Integrate low air loss surface to prevent pressure injury and line management safely, system built-in. With this, help with the nurse function can make the nurse do a very good job and less of a backstage when they're doing a lot of nursing with the patient in very, very sick in ICU. Another support device like tilt table for passive upright training, seat pedal bite for active movement, even whiteboard bedbound patient, ceiling overflow, or floor lifts that assist while transfer or portable ventilator to allow movement while intubated. These tools reduce physical strain on staff and help patients safe during movement. Nearly the last slide that I will show a little bit of the indicator. The indicator in ICU that we follow, like the mobilized rate, the mobilization rate, the percent in the ICU patient mobilized daily, or reduction in ICU acquired weakness incidence, or shorter mechanical ventilation duration, or even short ICU length of stay, and improve discharge independent, like walking out from the ICU. Track this indicator monthly, or quality improvement depend on the data. So in the conclusion, as we conclude, we want to leave you with the 5 key takeaways, especially important in the ICU context. First, early mobilization is nursing-led, safe, driven, and patient-centered. And this applies in the ICU perhaps even more so because these patients are their most valuable. Second, ICU nurses are often the first to assist, act, and advocate. It's often a nurse who notices a patient is ready to sit up dangling, or stand off the bedtime or the bedtime. First, early mobility is not just a task, it's a strategy to prevent harm. In ICU patients, it's reduce pressure injury, delirium, and help wean from ventilation sooner, while preserving their dignity and function. And fourth, sustainability ICU mobilization requires teamwork, checklists, and leadership support. When everyone is aligned, nurse, physiotherapists, physicians, it's become part of our culture, not an exception. Finally, don't underestimate your impact. One nurse, one ICU patients, and one small support movements, like setting up, can be the beginning of recovery every step concerned. So, with the final slides that I will ask you, so leave you with this question. If not you, then who? If not today, then when? And let's go back to our unit, not just the knowledge, but what purpose, because one small step lead by the nurse can change everything. Thank you.
All right, thank you so much for your insights, Dr. Yuwadi. So just a quick reminder to our audience that if you have any questions, feel free to send them in via the Q&A tab at the bottom and we'll get to them later. All right, for those who have just joined us, interpretation is available in Thai and Vietnamese. You may select your preferred language from the interpretation tab at the bottom of your screen. Once you've selected that, kindly ensure you mute the original audio. All right, I'll now like to introduce our second speaker, Dr. Fahim Ahmad Khan, Head and Senior Consultant, Department of Intensive Care Medicine, Ng Teng Fong General Hospital, Singapore. Dr. Fahim, please.
Thanks, Cindy, and thanks, Dr. Yuwadi. Can everyone see my slides?
Yep.
Okay. Good afternoon, everyone. I will just take up what Dr. Yuwadi been talking about, early mobility in ICU. It's not something new phenomenon. It's been there for many, many years, but it's taken a bit more value nowadays with more data coming out. We're going to just talk what exactly you mean, why, how, and what do we do for it. As Dr. Yuwadi explained, what exactly it means is more passive and active movements and training. The exercises can range from variety of things, basically. Main thing is, what do you define early mobilization? Does it really have a definition? When does it start? Is day 1, day 2, day 3, or day 5, which I'll go through in a few minutes. Before we go in, I take you a background. Why do we talk about early mobilization? Generally, if you notice anybody comes to intensive care, we all get scared because we have high mortality by the time we become sick, come to ICU. But ICU care have changed over the years. It's got better and better. More people are surviving it. If you look at it, as low as less than 20% people only die when they come to critical ill in ICU. And the 3-year survivors of patients with severe sepsis is getting better and better by every year. So if more people survive, what exactly are they surviving with? Are they surviving by going back to their baseline? So, but we notice that because when more people survive, more data comes out, we analyze them and we find them. Actually, yes, we're able to make them leave, but we leave them with a lot of problems. One of them is ICU acquired weaknesses. Because this is one of the things, yes, you survive the first hit, you become weaker, go ward, go home, but you end up dying because you have increased mortality because of your ICU acquired weakness, more prone for infections. In doing ICU acquired weakness, it can be a variety, as you know. It can be a polyneuropathy, myopathy, it's a combination of both. And one of the common problems is giving out a neuromuscular blockade for treating patients, especially like ARDS. People have tried all kinds of treatment for it. Steroids makes it worse, actually. Insulin therapy to make CIP, CIM, but not much of benefit, small, not very good. The key is, yes, you survive, but you become weaker. If you become weaker, you're high chance of getting sicker again. Not only getting weaker, but we also have psychological problems, basically. So you have first become sick, become critically ill. Medical professionals does XYZ, you make them better, but data shows you leave them crippled, because by most of the people end up having a lot of weaknesses. They reduce mobility, they become depressed. As much as 30% of the patients are depressed. Imagine 33% of the patients were not able to go back to their baseline, or not able to go back to their work. So imagine a whole cocktail of things. Become sick, go to ICU, you survive, but become weak, you become depressed. It's not a good phenomenon. It's now question comes, are we able to provide holistic approach? Can we do something about it? Not only saving life, but trying to make them better and going back to their baseline. Because we know, as Dr. Iwari talking about, a lot of those things by helping them mobilize in the initial phase. It not only helps in reducing ventilation, it has a positive impact holistically. Reduce depression, reduce anxiety, less post-traumatic stress disorders, and less chance of you getting readmitted or dying within a year or two. So these are a few things which have been noted to happen over the years, basically. Then we look at that information, the data. Has lots of studies been done over the last 20 years? A lot of studies have been done, but most of them are smaller studies, most of them retrospective, prospective. There have been some RCTs, for example, done by Dr. Cheng and his team. Look at 39 patients, they look at the time, and they notice that by doing early mobilization, you may reduce your ventilation-free time. You improve your cognitive status. So a lot of small studies have been done over the last 20 years to look into early mobilizations. People look at, like the Thompson study, which look at the distance of ambulation by mobilizing them early, to go faster and earlier to mobilize them. If you look at Dr. Shetwak studies, it noticed that not only early mobilization helps in reducing the incidence of delirium and ventilator-free days. A lot of the studies have been done over the last 10 to 20 years. But yes, not big studies, but the signal is there, telling us basically early mobilization is the key. It helps not only physical strength, it's also your mental strengths. If you look at things, survival rates gets better, weakness gets better. Then the question comes, another study we look at RCTs. I've done at 2 sites. They did at usual same thing, daily sedations and daily spontaneous breathing trials. When you talk about early mobilization, early rehabilitation, the question comes, what do you mean? Is day 1 or day 2 or day 3? In this particular study, they did on average second day of patient being intubated, patient had early mobilization, early rehabilitations. And the data shows that you get back to the baseline faster, your physical function is better, and less ventilator days. These are some of the studies pointing towards the signals telling us what we should do and we should be doing. But same time, there's a study which came out a couple of years back, team studies, slightly bigger study of 750 patients. They look at early mobilization and as well as the standard care. But if you notice, by the time 2 years back, the standard of care has already gone up. People by default are already doing early mobilization, early rehabilitation on a basis, basically. And if you look at in the study, if you go in the nitty-gritty of how things have been done, the usual care group actually had more mobilization compared to early mobilization. In this study, they showed that there were adverse events. Yes, we all know if you do early mobilization when they're critically ill in the beginning, there are risk factors, adverse events. But I'll explain to you in a minute or two, but there are ways of mitigating this. But you still can do early mobilization, early rehabilitation. You may have adverse events, but you can mitigate it. So this study says, yes, it does not improve length, make them patient alive, but we are looking at not only length of stay, but we're also looking at many other things. This study says increase adverse events. So now are we going to do or going to stop? After this study, which came out a couple of years back, my answer is, if you ask in my view, I will still persevere with early mobilization, early rehabilitation, but have a mitigating factors to reduce the adverse events. So before we go into how to mitigate it, as Dr. Iwari talking about, what are the components of ICU team? Different countries, different hospitals, different systems have different combination of teams. Generally, we have one physiotherapist, nursing attendant, and a respiratory therapist will help you to mobilize the patients. These are ideal team, what you need. Some hospitals across the world, we have more better resources. They may have mobility team on its own, separate from nurses. So, example, not only the staff, what equipments you may need, especially patients who are intubated, you may need a portable ventilator, ambu bag, or walker or wheelchair. And if your patient is sedated, what else extra devices you may need? For example, you may need cycle ergometers. People have looked at neuromuscular electrical stimulation as well to mitigate and having adverse events, especially when mobilizing the patient. Can we have passive muscle contraction by neuromuscular electrical stimulation? But again, it depends on the resources which are available in each unit and each hospitals. These are some of the things what you can see in the pictures. On the right side, you see the nerve stimulation, tables, and cycle ergometers. Not only the staff, we also need to have the right equipment and the right training. Before we go into people start looking at, can we have a criteria? Yes, we need, as Dr. Uwadi pointed out, we have a checklist. Early mobility, yes. Early rehabilitation, yes. But we can have a checklist, when to start, how to start. For example, this is a scenario where simple checklist will take less than 2 minutes. Is the patient cooperative, following commands or not? What kind of oxygenation patient is on? What kind of ventilator support patient is on? If the PF ratio is at 100, more likely to be 6. More than 100, patient may be on better track, getting better. Is patient stable or unstable hemodynamically? If none of those things are there, yes, you can initiate straight away. So if I have protocols, you don't need a doctor's orders. If you meet the criteria straight away, it can be nurse-led, physiotherapist-led, early mobility, and early rehabilitations. Not only that, you can protocolize it, you can standardize it, but you also need to customize your different patients. That's another key. When you look at all the studies is, are we customizing it or are we using standard protocol? Because certain patients can do on day 1, certain patients may do on day 3. So we need to customize it. And what kind of mobility or rehabilitation are we looking at? Are you looking at a respiratory-wise, cardiovascular, neurological, or combination? How long you're going to do it? If you're going to do patient go ventilated on oxygen, can we increase the oxygen to before I mobilize it so you don't have less adverse events? If you're on vasopressors, can I adjust the vasopressors so less chances of you having adverse events? Before we go to mitigating factors again, there's a lot of barriers. As Dr. Uwadi is talking about, it can be patient, structural, clinical, and process. Yeah, people had to look into it again. People had to look at adverse events. The team study said adverse events can be as high as 9%, but data shows on average, around 4% of the patients will have adverse events if you're not keeping in mind how to mitigate it. So these are studies which have looked at what kind of adverse events you can have. But on general per se, it's less than 4%. But if you look at the benefits you are able to generate with using mitigating factors, it's a huge impact. So now coming back is mitigating it. How do we mitigate it? So yes, I know patient may have the criteria. I need to mobilize it because we know it may have benefit down the line, but how do I mitigate when they are stable, unstable kind of things? Yes, you can, when you're having patient vasopressors, don't mobilize patient for minimum at least 2 hours after the last vasopressor dose. If the patient is on ventilator, increase oxygenation levels before you starting oxygen, so you drop this one down. Look at a sedation scoring system, what sedation patient is on. Look at the patient motivation levels. Please encourage the patients so they help in benefiting them. So a lot of those things are there. Yes, the risk factors are having lines, drains, mobilities. But if you look at it, I give you an example. All my upper GI patient after Ivor-Lewis esophagectomies, they have epidurals, they have minimum 2 chest drains, but on day 1 itself, they are made to mobilize 100 meters in the ICU. Twice on day 1, 3 times on day 2, with epidurals, drains, moving on. But yes, it can be done, but you need to protocolize, standardize it, customize it. Yes, you need some bit of extra help to mobilize a patient. You can't depend only on the nurse, but you can have mobility teams, you can have physiotherapists to add it on to that. The key is we as medical professionals, we need to believe in it and create systems for it to be done efficiently. Planning, asset planning, education. That is the most important thing. If resources allow, I know some countries in the world may not have resources. Can we bring family here? Can the family be involved from the day 1, day 2 in rehabilitation? Can they help out as an extra pair of hands? immobilizing the patient. So we need to think outside the box. Not we don't have resources, but also that can we have family members' involvement. I'll give you an example. We run post-ICU clinics in Singapore in my hospital. This is the exact the patient feedback was when we saw them few months later. If you look on the right, it says, I'm unable to walk as far as I used to. I feel breathless all the time. This is the patient we follow up after they get discharged in post-ICU clinic in my unit. These are young patients who become unwell because of pneumonia. And you see them a few months later, you feel, yes, your life has been saved, but you're not able to go back to the baseline. So these are real life scenarios. What we get feedback from the patients if you're not able concentrating medical treatment as well as the rehabilitations. It's another scenario. 49-year-old patient, independent gentleman, absolutely fine. Unfortunately, he had very bad pneumonia, went to multi-organ failure. Almost 3 months stay in the organization. He had tracheostomies. But if you notice, a few months later, when we saw him, he was very bad functional decline. He was had to use walking sticks. He was feeling breathless. And these are things we want to avoid as much as possible, or at least mitigate it and reduce the incidence of it, especially the severity. If we can do that by doing multi-level kind of thing, medical treatment, yes, early mobility, yes, early rehabilitation. If you see the patient trajectory, please follow the patients up in ICU, not only in ICU, follow them up in the wards. The continuation of those things needs to be done. I'll give you an example. Early mobilization not only ends in ICM department, it also has to be continued because another common phenomenon we have, you may start early mobilization, early rehabilitations, but as soon as they go to the ward, the whole thing falls apart because you may not same level of service. NTFGH stands for my name of my organization, Anting Fong Hospital. We have continuation because post-ICU clinic, we have physiotherapist. Our ICU physiotherapist continues the care for first 2 days when they go to the ward. So not only we have early mobilization, we want our physiotherapy to continue the mobility and the plan created from the ICU down to the wards. So what they do, for example, they run physiotherapy outreach service. They go and see the patient, make sure and collaborate with the general ward physiotherapist. If you know, generally ICU therapists are the most senior physiotherapists. General ward can be the mixture of young and senior. So now we have standardized care, not only from early mobilization, early rehabilitation, but also continues to the wards. And you proper handover take not doctor, nurses, but also to physio, which makes it a big difference. This is an example of what we do, my physiotherapist does in my organizations. How often you do it. In ICU, you may do it frequently once a day, general ward, and outpatients when followed up. So we have created a system in place now. Early mobility, early rehabilitation, ICU physiotherapist continues into the ward level, handled physiotherapist, and same physiotherapist can monitor the patient when they go home in the outpatient clinic. The standard of care and single team maintains the quality. I'll give you other example of how it's been done across the world, some organizations. MT stands for mobility team. So if you have mobility, you can start from level 1, 2, 3, 4, you can grade it up. So if you have mobility, you can do range of movement passive when they're unconscious. When they start getting better conscious level, yes, you can do your passive range of movement, turning as usual, but you can start slowly, you're sitting up, active motion of movements. They're getting more better, more strength goes up, you can sit them on the edge of the bed. If they're able to move their legs, then you can start mobilizing them and do most kind of things. So you can have a tiered way of systems, unconscious, conscious, getting stronger, and stronger. So continuity goes on, and we see that it can be done. The adverse events can be mitigated. Continuity needs to be taken care of. So I conclude by saying that, yes, is a risk are there, adverse events are possible, resources needs to be done, but where there is a will, there is a way. Because this patient not only saving their life, they need to go back to the baseline, back to what they were doing before. We don't want them to be crippled and have second head, get more infections and die within a year or two. So it will reduce a lot of those things are coming up. So adverse events mitigation can be done. Thank you.
Thank you very much, Dr. Fahim, for your excellent sharing. And good afternoon, everyone. I'm Marvin from Baxter Healthcare Medical Affairs, and I will be your moderator for this afternoon. Thank you very much, Dr. Yuwadi, for joining us at this live Q&A. Again, we are opening the floor to questions or comments you may have for our two speakers. Please feel free to type at the Q&A button below your screen. Okay, while English can help us understand the questions better, yes, please don't hesitate to use either Vietnamese or a Thai language if you feel more comfortable asking questions using your own native language. We do have some interpreters on standby in the call with us. And for this similar concern, could I also please request Dr. Yuwadi and Dr. Fahim to speak a little slower for our interpreters to be able to catch up during the Q&A. This is very much appreciated. All right, maybe I can pose some questions while we are waiting for some of the audience to type in. And this could go to either of you, Dr. Fahim or Dr. Yuwadi. Are there certain patient populations or conditions that pose more significant challenges for early mobilization? And if so, how do you address these?
Dr. Yuwadi, you want to go?
Yeah, I think you go first.
Yeah, I think end of the day, it all comes down to the resources available. One thing, you're having a systems in place that we are all targeting early mobility and rehabilitation. Yes, you can get all kinds of patients. It give you a scenario complex one like traumatic brain injury or road traffic accident. They come with head injury, they can come with chest injury, can have pelvic injuries. The question comes, yes, you worry about infection, worry about bed sores, you worry about DVTs. Can we mobilize them? Yes. The key question come is like, what do you worried about? Whether can do something on day 1, day 2, or day 3. Doesn't mean it becomes 0. You can have this low example, you can do passive range of movement, one part of the body. You can do simple things like turnings, those kind of things. So you need a proper plan and customization of individual needs, and can be done.
Yeah, on my perspective, a lot of challenge in the ICU from my experience, especially nowadays that we shortage of staff, and then the continuity of doing the mobilization is a bit not really at follow as we had. We said that we set up a system, but the system, I'm not sure, or we know that the continuity is very important. Like when I heard Dr. Fahim talking about the system that you use a lot of physiotherapists, right? I don't know that in the system, like there are a lot of physiotherapists, of course, because of their knowledge and their skill is very, very much for the early mobilization for the patient. But in most of the system in Thailand that we can share with you, that we have lack of both more physiotherapists. So we have difficult to set a system, a complex system that we can save or we can help a lot of the patients. So in your system, maybe can I ask the Dr. Fahim? Can I ask you? Right? In your system, depend a lot on the physiotherapist team, right? And you have a lot of physiotherapists in your team?
I think we have physiotherapists for us 7 days of the week in ICU. So we do utilize, and most of our physiotherapists are senior physiotherapists. In the wards, we have physiotherapists for 5 days. On Saturday, Sunday, if they need, they're on call basis.
Okay, so they have to go to another ward to do, or you just have exactly certain person who work in ICU?
Yes,
it's better than, right?
Yeah, so we have dedicated people for ICU. When they cover ICU, they don't cover the wards.
Okay, that's very good. Very good. Okay.
I'm seeing some questions posted on the Q&A button. Someone is asking for a checklist for mobilization. Maybe we can reach out to this HCP if we can connect with our representatives on the field, and maybe we can get you in touch with Dr. Fahim and Dr. Yuwadi after the call for this checklist. But there's a question here on, are there any contraindications for early mobility?
I think one of the slides had the way I given the, and Dr. Yuwadi also mentioned,
Yeah.
their standard contraindications are there and the standard indications when you can start. Yeah.
Yeah. So in my slide, like we are not like it's a box. There is no box in the line. That is the checklist that I said. You can check like vital sign or whatever. In my slide, they got already checklist item that we should checklist when we're going to doing early mobilization for the ICU patient. Yeah. And a lot of checklists that are available in the website and the evidence-based practice, which in each checklist we should choose that able to use in our practice or not. Some checklist is very complicated, and some checklist is very easy to start, something like that. So.
Thank you very much, both. Both of you were talking about staff earlier. There's a question here from one of the audience. How do you start early mobilization if you do not have enough staff in the ICU or ward? There's not enough nurses or not enough physiotherapists.
So for my work, we have not enough staff. We try to combine in every day of nursing function, like in the morning, they have to do the hygiene care or whatever care. So we try, like they have to, what you call, turn the patient or whatever. This is some kind of idea of early mobilization, which in our try to put like the activity, which activity that sometimes they don't understand, they don't even know that is, we can include in the early mobilization, right? So make them look at the work that they're doing every daily life or routine work can value to the word we call early mobilization. To conclude my set is that we start early possible, even when the patients just arrive in the ICU. After we check or whatever, we try to change the position because we have one by one, right? One-to-one patient and nurses in each bed. So they have to combine their routine work with the activity that we call mobilization, with not make them feeling like that they don't do anything about the patient with the mobilization, which as ICU nurse, they know that early mobilization can help the patient to go to out of the ICU quicker, to make the patient strength to whatever complication that they will come after the disease of each patient, something like that.
Thanks,
I
Dr.
don't know
Wadi.
that.
Do you see the same barriers, Dr. Fahim, staffing challenges in Singapore?
In Singapore, at present, in intensive care unit, we are blessed to have decent amount of staff, from nurses to physiotherapists to dietitians. So we have less. I think we have more of, not the staffing wise, we are more of the perception. Should I start today or tomorrow? Because you worry about ready to do, not to ready to do. For example, some of the questions they ask was any protocols and will you reduce benefit? Okay, I'll give you a simple thing. We are doing post ICU clinic in my unit. We follow patient up 4 weeks later in the wards. We follow them up 3 months in the outpatient clinic, post ICU clinic. When we started 2 years ago, we noticed a lot of weaknesses in the patient survived. When we started getting the ICU physiotherapy going into the wards and following up continuously, we realized that, and being more aggressive early mobility, our levels of diagnosis of physical weakness 3 months later post survival has come down. What I mean to say is we have learned over the last 2-3 years in our own practice, if you do early mobility, early rehabilitation, continue the quality of physiotherapy, the highest standard in the wards also, when we come back to the post ICU clinic, we are seeing the signals, less physical problems we face now.
Oh, and can I add up you something that maybe can help people understand the work I mean, situation in a ward, not like in Singapore, because in Singapore, when you look at the doctors for him, I really jealous Dr. Fahim to stay in a very good environment like that. In our system, we have physiotherapy that I said to you that he had to look at all the patients in the ward and in the ICU. So the time that they come to the ICU is limited. So the nurses who work a lot. In another thing that I want to corroborate is that how we make the nurse aware and try to get involved in the early mobilization. We call the leadership, we set up like TCAP. A lot of nurses or administrator understand what TCAP mean. TCAP mean transforming care at the bedside. We put it like a project in the ward. Like, okay, you as a nurse, you can do anything to change anything, environment in your care. Like you can start from your one nurse, one patient, one shift at a time. So the early mobilization in ICU is one of the popular program. See the nurse, they try to, compete each other to make that who is the one who doing the patient mobility is better. They count by the length of stay to each patient. They count by the indicator that they follow is that the length of stay and how long that they're been off the ventilation or something like that. It's made in the area that the patient is very heavy and needs a lot of staff, multidisciplinary team to look after. But when it's heavily depend on the nurses, myself as the nurses, another way that we try to make them get activity that make value for themselves and make value for the patient, which the leadership come in with the setup, the program, something like this, to know that we know that you are doing a good job in each area. That is the way that we try to do it. To try to make the lack of staff is like, okay, we have one staff, but they can do like one staff, like doing like a two nurses doing the job, something like that. But Dr. Fahim, he not really understand, I think, or maybe he don't need it because he got a lot of team.
No, I know we understand absolutely. We even same thing sometimes when things get quite busy. It's tricky to do it. And also the timing, whether you want to do morning or afternoons or evenings, you want to give patients a rest because around some morning happening. So a lot of logistic questions are there, but the key is like if you plan beforehand and if you have a customized standard protocols, taking all the strength and the weaknesses. So I look at different ways. I work in a system where I have a lot of resources. Before coming to Singapore, I used to work in England. On paper, England says rich country, but I'll tell you, if you go in National Health Service hospitals there, it's very difficult to get physiotherapists in some of the units there on all the time. So we customize the kind of thing saying that can we encourage patient also to move some things on their own? Can we use ergometers? Can we use technology like beds, basically, which helps the nurses to press a button, move things around? Can we have any devices out in the market which are not resource heavy kind of things? As you pointed out, some patients nowadays quite obese. I see patients coming 120 and 40 kilograms. My nurses weigh 50 kilograms. My physiotherapy weighs 50 kilograms. Even my physio and nurse combined weighs less than the patient. So we do see that. Now the question comes, are there devices out in the market? Example, the beds itself, for example, or they have hoist machines which help it out to reduce the workload or the physical strength needed to do the physiotherapy. So we also trying to look at, but it don't have to be expensive. Yes, there are devices which are expensive. We want it cheap, cost-effective, beneficial, and help the staff on the ground, basically.
Thank you both for sharing your experience on how to overcome this staffing challenge. I'm going through, some of the questions here on the chat, and we know our audiences are coming from different cultures and different backgrounds. So there's a question here: what is your opinion or experience on integrative management for rehab and mobilization? Say, combining or integrating Ayurveda from India or TMS, etc. with some of the known protocols that you have? Uh, Maybe
Can
I'll
be
ask
used as part of
Dr. Yuwadi first. Are there like
hello, can you hear me?
traditional
Traditional what?
traditional Thai practices that you incorporate into early mobilization therapy?
In what? I not get it for this question. Sorry, Dr.
Yeah,
Fahim.
it's
So
yeah.
what they mean to say is like alternative medicine, like acupuncture, Ayurveda, those kind
Yeah.
of things,
Okay.
can they help out in early mobility and early rehabilitations? So that's the question they have been asking.
Mm. I don't
See,
think
the
that
key,
I have
the key,
yeah,
yeah.
I don't think that I have this kind of thing in ICU. Advice, I know it because in ICU the patient very sick, so I have no experience of this. You have any?
So the key
Like
question
massage?
comes down, yeah. So people do ask basically is like for do massage, acupuncture, XYZ in ICU settings. The question comes, who provide this service? That's the first part. Even if you say, okay, go ahead, I don't have no issues, traditional medicine helping out in mobility. The question comes, should hospital provide or family provide? The second part to it, because the question comes, you're not going to have, first of all, you need a proper physiotherapist, need a proper training, need to know when you're sick and unwell, what to do, what not to do, because these are complex patients. Compared to I go to a Ayurvedic clinic or traditional clinic or acupuncture clinic, I'm fit and well with no medical problems, you can do what you need to do. Can you transfer those kind of expertise into a hospital settings in ICU who are sick and unwell? And because a lot of issues are there. For example, can I use acupuncture in a patient who is sick in ICU whose platelet count is low? Because we will not allow patients with low platelet counts to have punctures basically, because it's all punctures in the skin and the fascias. So there's always that balancing act, and the financial aspect is involved.
There's a question on the chat. Oh, sorry, Dr. Iwadi, are you sharing
It's
something?
okay. I agree with him that if the patient have strength enough or whatever, move out from the ICU in the ward, we have some. We have acupuncture, we have whatever, depend on the patient preference. We now in Thailand, like we try to promote like a lot of massage and things, something like that. So the patient can if their preference, we can get for them, but depend on we assess the patient. Yeah.
I think
But
there's
in
a question
ICU,
here.
yeah.
Thank you,
Okay,
Dr.
sorry.
Iwadi. There's a question here. I think it's directed to you, Dr. Fahim. You shared in one slide, there's a systematic review suggesting no significant difference between ICU recovery and early mobilization. And then there's another study suggesting early mobilization is beneficial. The question is, how do we reconcile this conflicting data?
Okay, so very good questions. I think I just had it earlier on. When you read papers and articles, you need to read basically is what is a usual care, what is the intervention group. For example, the team study which came out 2022 saying that there's no more difference in mortality. Why am I looking at mortality for 6 months patient talking about early mobility and rehabilitation? Number one. Number two, the usual care was higher standard or lower standard. The problem comes over the last 10 years, 15 years, because of awareness of early mobility, the standard of care has already gone up. Now suddenly you're trying to bring intervention group, which also similar standard. So your comparison is not exactly the equal per se, or one is up or down basically. But if you look into in detail data from the team study of 750 patients, actually the signal already there inside saying that early mobility does helps. If you look at a usual group, how long they have done the physiotherapy, how long they're doing it, these patients were able to stand on day 3 and day 5. They're able to stand up on their own.
Okay, thank you, Dr. Fahim. Both of you earlier shared about the involvement of family. There's a question here. How can family members helping patients in early mobility? Oh, maybe how can family members help patients in early mobility? And is there any guidance for family counseling or training?
Yes, this is quite what you call the knowledge or the pattern or whatever that we try to encourage the patient. But in the in the general ward, it's not difficult. The patient get involved, but of course in the ICU, they just even come too close to the bed. Sometimes they're scaring, but we can ask them to like at my experience, instead of I ask them to do like, okay, hold the patient, passive exercise, do the pumping or whatever. But I change the way that they make them too close or move to touch the patient, like, okay, the patient needs touch from the family or whatever, like make them to have activity with the patient, they can do it. But if I told them that help the patient to do the mobility or whatever, try to explain, but they not cooperate, right? But the patient now is not like the patient at the time that I a new nurse. The family is not like the time that I am a new nurse, because at the time that I'm a new nurse, the family try to be a very connected family, right? They come together, they visit the family, and then they try to do whatever. But nowadays they have very short time, short time. They come see, look at sometime at the mirror in the glass window, like, okay, oh, their family is still there. They have very busy. They come out. So this is the way that family, what you call culture, I think it different. I don't know, Dr. Fahim. I want to.
No, I agree with you, Dr. Yuwadi. The key question comes now is, first part, number one, we believe in early mobility rehabilitation. Number two, the difference in different countries, different society, different resources. You make them aware, this is the benefits. Can you help us and cooperate? Do you have the time to be involved, basically? It's no use of complaining, saying that you're not doing X, Y, Z for my loved ones. The question comes now, is your loved ones, we're trying to do our best, we need your help. So we need to turn around to the family and says, we need your help. We need your time to make them better. So I think we need to start changing that. What happened in the modern society, we dump loved ones into the hospital. We expect the hospital to do everything. Yes, hospital can do everything, but at the same time, they don't want to pay money. They don't want to pay for the resources. So you need to have a fine balancing act. We need to have open communication, open channels of family. We want the best care for your loved ones. These are the things are needed. For it, whether you can provide your physical help or monetary help. Generally, we say, please provide more physical help, more better, because imagine your loved ones helping you out in coordinating. It also helps your psychology of the patient, because they know their loved ones. They know their moms, dad, brothers, sisters, wife, husband, who they are, what they are, how they like, what they don't like. It's a bigger motivation. It comes always from the family. But I think, modern society is different, but we need to change that thing.
And another thing that I worry about in my experience now is that because of the expectation of the family, that we know that when they send the patient into the hospital, they expect healthcare team to do everything for the patient. And then when we try to ask them to help their own patient, their own family, sometimes the new generation, the way that they communicate, it's not really like my generation or maybe someone generation. Make the family is very angry that we are not really look after the patient or try to put the nurse job to the family or something like that. I work at the nursing council. Now, at the moment, we got a lot of complaint from the family and relative about the communication style of the new generation. That is another thing, that there is an obstacle of the conversation. We try to convince, the way that we convince them is maybe we have to train our nurses to do in a professional and in a way that, I don't know, but is it what you call the thing that is a challenge for the new nurses? How to make the family cooperate with them to do for the better health of their own family member.
Okay, thank you both for your answers. Okay, I know both Dr. Iwadi, Dr. Fahim, both of you have shared some devices that earlier in your lectures, but are there some other tools or technologies that you both find useful in facilitating early mobility?
I'm not, you want to ask me? I not support anyone. When I'm a nurse, I think, okay, if I have that, it and have this to help me, it's very good, right? Like I look at the new devices that I see it, not many company like help us in the COVID. I remember that they got some kind of bed that help us to turn to prone position very easy, or any device that to help us to doing the early mobilization that can help the nurse doing the better job or something like that. I think that it will be the best for the nurse in the moment. I know that it's very expensive, but I just a dream. I want in my ICU, if I have every bed, the nurse will be a lot better and the outcome of the patient will be better.
Yeah, I think the key question I look at is, I won't go today and change my beds in the hospital, it costs money. But if you're going to replace a bed or building up a new hospitals, look at what you need in the whole patient care, because this is one-off cost which you're going to use for next 10, 15, 20 years. If you're able to get the right devices in the first time itself, or when you're buying first time or replacing it, get it right first time. So if you want to go bed which can tilt, can turn, you have devices which can move your arms, legs passively, go for it. But yes, but same time, you think outside the box. I won't just say go to your management today and say change my beds. No. The thing I will say is get the concept right, get the protocols right, get the training right, come back to the devices if you have any issues, but look at the cost effectiveness also.
Okay, thank you very much both. We're almost down to our maybe last question, or we're running out of time. There's a comment here in the chat that in Vietnam, they do have an acupuncture and therapy massage to help the patients recover. These hospitals, other hospitals forward or endorse these patients to the Acupuncture National Hospital and other hospitals where patients there are sent for better recovery. Thank you for that information. Maybe one last question for the both of you. As research evolves, what emerging trends in early mobility do you think will shape the future in critical care?
I think I'm not talking because I'll be talking because of Baxter is the sponsor. I'm talking as a nurse. I think that we need more like in the type of AI or a lot of developing technology. I think that in the future, the mobility will be better if we have the right tool to help, because for my belief, I'm not rely on the human being only. We have to have human being and technology that try to advancement our activity in doing our job. That is my opinion.
Yeah, so I would go on two things basically. I think not only mobility, the combination of mobility and nutrition goes hand in hand. As the first part, I think we need to look at not on its own, we need to look at combination of mobility and nutrition, the first part, where we can look at how you can't mobilize, don't feed the patient. But if feed the patient, don't mobilize. I think both go hand in hand. And second thing, what we need to look at is holistic approach. Second thing, what we look research perspective from the day one till they go home. Is it only ICU? Does early mobility, early rehabilitation in the ward, and follow up to that. So it's an end-to-end process we need to look at, not only for a few days. So these two things I would be interested going forward, the research should concentrate on.
Okay, thank you very much for your time this afternoon, Dr. Fahim, Dr. Iwadi. I'm afraid this is all the time that we have for this Q&A session. Thank you, everyone, for being engaged and sharing your questions over at the chat button. I'm afraid, we could not get all of the questions responded to. But yes, feel free to tune in for further, sessions that would talk about early mobility in the ICU or sepsis coming your way from your field representatives. Yeah, thank you very much for joining. I'll turn it over now to Cindy.
Yes, thank you so much, Marvin, for moderating the Q&A session, and also thank you to our speakers for taking time out this afternoon to take questions from our audience and share your insights into early mobility during your individual presentations. We have now come to the end of our webinar. A big thank you to our audience for joining our webinar today. We hope it has been a valuable session for you. So do look out for our upcoming HMA webinars in the coming months. See you soon and have a good day ahead. Thank you.